Right, well, good morning, everyone. Thank you for joining us on this Saturday morning. Really glad for your time. Joining us this morning, I'm Mina Lobbous. I'm one of the neuro-oncologists at the Brain Tumor Center at Cleveland Clinic. Also take care of adults with neurofibromatosis type 1, type 2, and schwannomatosis. And for this talk, we will be discussing neurofibromatosis type 2, what are current treatments we have, what's kind of in the future for care for NF2. Yep. So just for disclosure, I'll be discussing some off-label use of medication. Off-label meaning these medications are FDA approved for other indications. These are the objectives of my talk. So neurofibromatosis. As you heard from Dr. Patel, there are different types of neurofibromatosis, with NF1 being the most common. It's 1 in 3,000. And it, the mutation comes from chromosome 17. And in NF2, it's less common, is 1 in 30,000. And neurofibromatosis type 2 and other form of schwannomatosis result from mutation on chromosome 22. So you hear neurofibromas, you hear schwannomas, are they different? And the answer is yes. They're made up of different type of cells, they look different, the surgical approach also is different, but they're both a benign type of what we call nerve sheath tumors. They grow from the layer that wrapped around the nerve. It's like electricity wire. You have the copper, you have the insulation wrap, and the nerve sheath is that insulation wrap. So they look different, and they're treated different. Patients with neurofibromatosis type 2 do not have neurofibromas. They in fact have schwannomas. So there have been updates in how we diagnose neurofibromatosis type 2 schwannomatosis and other type of schwannomatosis that came as we learned more about these tumors, their genetic background, and also to remove any confusion that may have happened in the past because of some patients with NF2 were called NF1 or vice versa. So this had been released 2022, and NF2, formerly called NF2, now is called neurofibromatosis related schwannomatosis, and this is the most common type of schwannomatosis. The other are less common, and we're going to talk briefly about them. So NF2 related schwannomatosis, formerly known as NF2, there's different diagnostic criteria, but if the patient has two hearing nerve tumors and he meets the criteria for NF2, if not, then we depend on this, what we call major and minor criteria. But most common tumors that come with this disorder is the hearing nerve sheath tumor. You also can have meningiomas. Oh, sorry. How do I go back? Sorry. I'm sorry. Sorry for that. Got it. They can have other tumors called meningiomas and ependymomas. In terms of genetics, it's like NF1. So it's autosomal dominant, and what does it mean? Basically, it does not skip generation. So if it's a 50-50% chance with each pregnancy to pass to future children. If the child got the mutation, the NF2 mutation, then also for them it's a 50-50% chance. But if they don't get the mutation, then they don't get the disorder. This does not skip generations. So there is no carrier. So it's either you have it or not, and if they have it, it's also 50-50 with each pregnancy, but it can be different. It can present different in different generations. It doesn't mean you will have the same type of distribution of the tumors like their parents. But also in about 50% of individuals with neurofibromatosis type 2 that we see in clinic, they are the first in the family to have it. Neither of the parents were, again, as I mentioned, there is no carrier. Neither of the parents have had NF2, just the mutation happened in that patient, and from there, again, for the future, it's also 50-50 chance, but it's quite common actually that we see someone and they're the first in the family to have it. As Dr. Patel kind of talked about NF1 and the MYC pathway, how does NF2 cause tumors? Well, think of it like the brake system. If the brakes here are the myelin. This is a protein that's can be malfunctioning or absent in neurofibromatosis type 2. And if the brakes are not functioning or not there, then we can have a unregulated or unchecked cell growth. And that's happened through a very complex network of different proteins, different pathways, but they all, that's how we talk about targeted treatment, is how we target these different pathways, try to slow down or basically put the brakes back on. So types of tumors that come with NF2s, that's an MRI that show here the hearing nerve tumor. So that's in 99% of folks with NF2. Meningioma, it's a benign tumors that grow from the layers that cover the brain, or the meninges. And that's about 50% of folks with NF2 will have meningiomas, but they usually have multiple of these meningiomas. The third type is called ependymoma, which is a growth from the lining, or not, the center of the spinal cord and the brain. Other type of tumor can be schwannomas in the skin, and it's like knots under the skin. Patient may also have cataract or vascular lesions called hematoma. What are the signs and symptoms that come with this hearing nerve tumor? So hearing loss, variable rate, variable degree. There are studies that have shown that the degree of hearing changes does not necessarily correlate with the degree of tumor growth. So we can see tumor growth without hearing changes. It's not like parallel lines. Other signs can be ringing in the ears, balance problem, vertigo. Facial weakness and headache are not very common. This usually happen if the tumors go unchecked or grow in size to the point that it push on the facial nerves, the nerves that move the facial muscles, or it kind of block the drainage, or push on the other, blocks the drainage of the spinal fluid, or push on the other brain centers that it can cause headache. But headache is not an early, I would say, symptoms in neurofibromatosis type 2. These are the mutations that can cause other type of schwannomatosis. These are more rare than NF2. And in this particular disorder, schwannomatosis, like SMARCB, LZTR, 22q, here genetic testing is required. We do genetic testing either from the tumor tissue if one of them got sampled or had surgery, and also from the blood. The patients with SMARCB, LZTR, schwannomatosis, they typically do not have hearing nerve tumors, but you would rather have these schwannomas elsewhere. These can be painful, and treatment options we usually kind of discuss are surgery or SRS or a stereotactic radiosurgery that's delivering precise focal radiation. There are off-label treatment, although that hadn't been studied in big group of patients like, bevacizumab or Avastin, and pain management, as we're gonna hear today from our colleagues in pain management, either medical or interventional. There was a clinical trial looking at this compound, a monoclonal antibody against the nerve growth factor. Unfortunately, it was terminated early because of low accrual. As I mentioned, the tumor is rare, and it took them several years, and only few patients got enrolled, so they closed the trial. So, clinical care guidelines in NF2. What's important is what do we watch for? It's personalized care for each patient. It's not the same. It's not the same approach to everyone. But what we look at is what are we watching for? What are we trying to achieve? What treatment options do we have? How often do we need to see the patient? Surveillance modality, and what is based on clinical trial, what is based on consensus and kind of expert agreement. But management for NF2, it can be, we start with, observation. That's for those with stable tumors. A lot of times these tumors can stay quiet and not growing for years. So at that, at that point, there is no intervention warranted. So we offer observation for, again, a stable tumor, no hearing changes, younger patient, and that include follow-up with imaging. That's in our multidisciplinary NF2 clinic. They see neuro-oncology, they see neurosurgery, audiology, ENT, as well as imaging. What about surgery? When do we, and Dr. Soni will talk more about surgery, but that's for, again, large tumors that cause compression or rapidly growing tumor. Radiosurgery or focused external radiation therapy for those that's unable to undergo surgery. And last is molecular targeted therapy. These are targeted treatment. It's not like big gun chemotherapy. In events there is a hearing decline, there is growing tumor, multiple growing tumor that makes, sometimes makes surgical approach kind of more challenging. Or in a combinatorial therapy approach, meaning patients may undergo surgery and molecular treatment, radiosurgery and molecular treatment. And as I mentioned, it's a team approach, it's a multidisciplinary approach, not just one physician making the call. So the goals of treatment, as I mentioned, is to preserve hearing. That's the number one. We treat patient, not picture. So it's not guided by the MRI, but how the patients feel. Preserve the function of other cranial nerves, including the facial nerve, swallowing nerve, speech, eye movements. Optimizing the quality of life, and also optimizing patients' outcomes, and make sure that despite the treatment, the patients are able to enjoy their day-to-day activities with minimal side effect. So again, the treatment, as I mentioned, observation, surgery, stereotactic radiosurgery, medical option, or clinical trials if available. So for the interest of time, therapeutic development can be quite a costly process. It may take up to 10 years from the drug showing a promise in the lab until it make it to the patient, going through phase 1, phase 2, phase 3. A lot of initiatives around the country, from the NF Consortium, from NTAP, the Children's Tumor Foundation, the RAINS group, try to advance this process. But some of the challenges in neurofibromatosis drug development is we're treating benign tumors, so it's hard to expose a patient to, medications that have hefty side effects. These are usually slowly growing tumors, so we have to factor in that part as well. And what also we're trying to achieve, we're not just trying to shrink the tumor, but more importantly, to preserve the hearing and improve the quality of life. This is the graph I showed earlier, was like how Merlin the defective protein in neurofibromatosis type 2 can interact with all these other pathways, and how the treatments target different targets. I know it's a very busy slide, but just, highlight how our medical option try to target these different proteins without exposing the patient to like a big gun, as I mentioned, kind of chemotherapy approach. So bevacizumab is one of the available medical option. It's an infusion. It targets a vascular endothelial growth factor, which is almost expressed in 100% of schwannomas. It's not a big gun chemotherapy, but it's considered a chemotherapy because it treats other tumors, including brain, ovarian, and colon tumors. Some of the side effects can be high blood pressure and proteinuria. So we monitor for these closely, and the drug has achieved, hearing response in more than 30% of patients, and tumor shrinkage in about quarter of those, like in the clinical trials that demonstrated efficacy in NF2. This is another slide of how bevacizumab, was started by finding in the labs that it targets this particular molecule, the VEGF, until it made it to the patient. And the way we look at shrinkage, it's 20% is usually the threshold we use to call it shrinkage. But in fact, if you look at the trial, almost 90% of patients that have tried bevacizumab had stable or improved hearing, and 88% also had a stable or decreased tumor size after 1 year of treatment. In that here talk about the efficacy, the tumor shrinkage, hearing improvement, but like all the other medication, the side effects can add up, especially with prolonged use on the proteinuria, and also plateau of the response. We see initial shrinkage, but after that, kind of it becomes more stable. Lapatinib is an oral chemotherapy that's FDA approved in breast cancer, has been studied in neurofibromatosis type 2. This is what we call a waterfall plot, and going up is the tumor growth on the treatment, down is tumor shrinkage, and this dotted line is like the 20% cutoff. So a lot of the patients who had or tried lapatinib had, I would say, tumor stability. Only few who had actually true shrinkage, but it's an option. Some of the side effects can be, especially the ones that we truly worry about, is cardiac toxicity. So it's not the first line we jump into. Bergatinib is an oral medication that's FDA approved in lung cancer. It's a targeted treatment. It's not a big gun chemo. Studied in phase 2 trials that enrolled 40 patients. And also that's another kind of waterfall. A lot of patients had, stability. Some had shrinkage, about 25% had shrinkage, but the majority had stability. Interestingly, that most of the efficacy were actually achieved in meningiomas and other schwannomas, not the hearing nerves one. So it's an option, it's an off-label option, but not the first one that we go to for NF2. Is there a role for MEK inhibitor in NF2? The answer is there is actually 2 clinical trials looking at that, but some of the preclinical or the lab experiment have showed that there is probably a signal of trying MEK inhibitor in NF2. And we have used it off-label in conjugation with bevacizumab. But there are 2 ongoing trials looking at MEK inhibitor in NF2. Solumetinib here in the US, and FCN59 is in China. What about axitinib? It's another oral medication. It's FDA approved in renal cell tumors. only 2 patients on that trial that actually had tumor shrinkage. So it didn't perform as we would hope it will perform. What about immunotherapy? You know, it has revolutionized the cancer care in the U.S. Schwannomas are immunologically cold tumors, meaning they do not trigger the immune system to identify them and attack them. So there are other ways trying to target these tumors, including using vaccine or cell therapy, manufactured cell therapy, checkpoint inhibitor, and last is bacteriotherapy, which is with a study injecting live attenuating salmonella actually into schwannomas, but still no efficacy results yet. So future for NF care is smart surveillance, ensuring we do targeted treatment, building community like what everyone is here for today. These are some of the resources that you can look up for NF2 ongoing trials and some of the initiatives around the country. And it takes a village, a lot of specialists from neurosurgery, neuro-oncology, ENT, ophthalmology. It takes a village to move the needle forward in the field. I know it was, you know, we can spend the whole conference just talking about neurofibromatosis type 2. I thank you for your time going over like this quick overview, and I will turn it on to my colleague, Dr. Soni, the co-director of the adult neurofibromatosis adult clinic, to talk about the surgery and advances in that field. Again, thanks for your attention this morning. Thank you.